Okay. Perfect. Now recording. Screen. And play. All right, welcome to the final lecture. Today we're going to go over sleep, scheduled and unscheduled drugs. All right. And I guess we're going to touch on alcohol use disorder, which we talked about last week, but we'll review it again. All right. Again, pharmacokinetics, make sure you know it. Sleep circuits. All right. So I'm going to try to simplify it as easy as possible. I know style makes it a little complicated, I guess, but there's two circuits that are kind of competing. So you have the wake circuit, which is from the ascending reticular activating system. We're going to look at that in the next slide, but remember, it's projections from the stem, the brain stem, that goes up to your cortex. All right, so those are projections of histamine, you have orexin or hypocretin, you have the monoamines, and you have acetylcholine. All right, anytime you block any of those projections or any of those neurotransmitters, there's a risk of the patient either having impaired cognition or, they're feeling a little bit drowsy. So that's the wake circuit. The sleep circuit is pretty much regulated by GABA. So when you increase GABA, that's going to make you want to go to sleep. All right. Once again, suprachiasmatic nucleus is like the pacemaker of sleep. So that's what regulates your circadian rhythm. That's located in the hypothalamus. If there's any issues with the suprachiasmatic nucleus, that's when you have issues with, staying awake or falling asleep. Okay. You also have homeostatic drive and circadian drive. All right. So homeostatic drive is your sleep drive. So that's actually driven by adenosine. So when a patient says that, that they're not able to fall asleep at night, sometimes I ask them, like, if they're depressed, what are you doing? Well, I'm laying in bed all day. So if you're laying in bed all day, you're not really burning calories, right? You're not breaking ATP. You're not creating adenosine from that breakdown. You're not going to build up adenosine, right? So adenosine is like money in the bank that makes you want to go to sleep. You have to burn a certain amount of calories and accumulate a certain amount of adenosine for you to feel drowsy. All right. So that's kind of like that's why when you drink coffee, which is a adenosine antagonist, it kind of prolongs that a little bit. The adenosine is still there, which is an inhibitory neurotransmitter, but it's blocking the receptor, so it's not making you tired, right? It's like a weaker version of GABA anyway. It's inhibitory. And also you have your circadian drive, which is your wake drive, right? Your wake drive, again, is your projections, your neurotransmitters that are going up to stimulate. Any questions? Okay. These are the different types of insomnia. I know I touched on this in the past, but you have initial insomnia, which is what everyone, I had this last night. I'm running on 4 hours of sleep right now. I couldn't fall asleep for whatever reason. That's initial insomnia. It takes you longer than a half hour to fall asleep. Middle insomnia is when you wake up in the middle of the night, right? So you wake up at 2 a.m. or 3 a.m. and you can't fall back asleep for whatever reason. Sometimes people have, it's a medical issue. They have to wake up and pee. Sometimes it's an issue with, they have nightmares. They have PTSD and they have nightmares. They get waking up in the middle of the night, right? That's middle insomnia. And they also have a hard time falling back asleep. So pretty much it takes them longer than a half hour to fall back asleep. If someone wakes up at like 2 a.m. and they use the bathroom and they go back to sleep within 2 minutes, of course, that's fine. That's normal, right? Terminal insomnia is usually what happens when people are depressed or they have a mood disorder. They wake up earlier than they want to. So for instance, if someone has to be up at 7 a.m. to go to work, for whatever reason, they wake up at 4 or 5 and then they can't fall back asleep. They're laying in bed, they're staring at the wall, and they feel exhausted because they can't sleep. All right. So whenever someone mentions terminal insomnia, that's usually linked to a mood disorder, most likely major depressive disorder. All right. And usually the treatment for that is treating the underlying disorder. So if someone has depression, you want to treat the depression, and then it would help terminal insomnia. All right. Middle insomnia, we use a long half-life medication. I like to use isobucol, which is Lunesta, or Ambien CR, which is controlled release of Ambien, which lasts a little bit longer than regular Ambien. Question? All right. Initial insomnia, you have many options: melatonin, histamine antagonist, serotonin antagonist, dopamine antagonist, right? You have orexin antagonists, right? So you have many more treatments for initial insomnia than you do for middle insomnia and terminal insomnia. Just keep that in mind. Initial is a little bit easier to treat. Just know this, all right? Scheduling of drugs. Really, if you don't prescribe anything at Schedule 1, all right, you shouldn't be trying to prescribe it. So that's like your illegal drugs: heroin, LSD, marijuana, ecstasy. I'm sorry, not marijuana. It's legal now. Sorry, that's outdated. Schedule 2 is your Adderall and your stimulants. And Schedule 4, obviously, is going to be your benzodiazepines. All right. So Schedule 2 is your stimulants, which is a little bit harder to prescribe. And they're a little more stricter with that. And Schedule 4 is your benzos. Okay. We don't really prescribe Schedule 5s in psych. So just 2 and 4s for the most part. Okay. This is the ascending reticular activating system. I think we spoke about this last time, but remember, these are projections over here in your brainstem. See that little bump? I don't even know where my cursor is, but In the middle of the brain, you have the TMN, which is the tuberomammillary nucleus, which HA stands for histamine. So that's the projections of where the cell bodies are that create a lot of the histamine in your body. All right. So the TMN responsible for production of histamine. Okay. The Raphe nuclei, obviously, is serotonin. LC stands for locus coeruleus, and NA means norepinephrine, right? So that's your projection of norepinephrine. So when someone's in a fight or flight response, a lot of times it's hyperactive locus coeruleus, right? If someone has flashbacks, hyperactive is locus coeruleus. Someone's having panic attacks, hyperactive is locus coeruleus, all right? Basal forebrain is GABA and acetylcholine. That's where the projections are, okay? Let's see, the other ones that are important. And it's not there, but just know that VTA is the major projections of dopamine and ventral tegmental area. So those are the two. Okay. Any questions? This is just for alcohol. Just remember the reason why alcohol gives you pleasure because it actually innervates the mu-opioid receptor also. So it simulates it, and that mu-opioid receptor is actually on the dopamine neuron, the VTA. So what's going to happen is when alcohol touches that mu-opioid receptor, it's going to tell the VTA to actually secrete dopamine. Therefore, that's reinforcement and kind of gives you pleasure. All right. These are the different opioid receptors. All right. There's no mu, kappa, and delta. All right. So mu and delta really are the ones that when you agonize those, that's what kind of helps, reinforce the medication, right? Because euphoria, sedation, right, makes you a little tired. They actually have new antidepressants they're trying to develop now that are actually kappa antagonists. Because if you look at kappa, the K over there, right, when you agonize that with an opioid, it actually causes dysphoria, right? It makes you feel agitated as well. So they have new, I think it's called S-methadone, which is an isomer of methadone that's a kappa antagonist that's shown some promise to help with depression. All right, this is MRI of the brain of alcoholics. Once again, enlarged ventricles. Ventricles means that obviously there's brain loss, neuron loss there. Okay. Also, same as schizophrenia. Wernicke's encephalopathy. Just know that could be reversible. So that's acute, and that's a thiamine deficiency. So before you give someone, if someone comes in the ER and you suspect alcohol abuse, make sure you don't give them glucose or dextrose. All right, make sure you give them thiamine first, because if not, what's going to happen is you need thiamine for cell metabolism. And if you give them glucose, that's just going to put more strain on the neurons. The neurons are going to have to work without thiamine, and it can actually lead to something called Korsakoff psychosis, or even more accurate, Korsakoff's dementia, right? Because that's irreversible and that's permanent for the most part. Okay, so Wernicke's encephalopathy is reversible. You give them thiamine, and it progresses to Korsakoff psychosis if you don't treat it. All right, so there's a triad of symptoms. Most of the time, it's ataxia, right? They're losing their balance. There's ophthalmoplegia, which is if you do lateral gaze and they follow your finger, you might see nystagmus, or you might even see that one eye might not move. It's called ophthalmoplegia. It's almost paralyzed. So maybe the left eye will move, the right eye will not move. I've actually seen that in clinical practice. And obviously, there's going to be a change in mental status. They might have issues in impairment, and they also have something they do called confabulation. Well, they're kind of like, not that they intentionally want to lie, but if you ask them a question, they kind of want to fill in those gaps, and a lot of times it doesn't make sense. So it'll be like a false memory almost. It's a confabulation. Okay, so change in mental status, lateral gaze test. You see nystagmus, the eye is moving, or ophthalmoplegia, one eye is not moving or drifting the other way. All right, and they have ataxia. They're losing their balance. You want to suspect Wernicke's encephalopathy. You want to give them thiamine as soon as possible. All right. Remember, thiamine is water soluble, so you can never give too much thiamine. Just pee it out anyway. You can't give too much, but you can give too little. So give more than you need to. All right. CWA. Everyone should know what this is. This is a scale that we use to see how much withdrawal patients are. And this is how we dose benzodiazepines also when we want to kind of treat alcohol withdrawal. I spoke about this last week, but there are some addictionologists that are able to treat alcohol in a controlled setting without using benzos. I've never done it myself, but there's some good studies out there that show that it's possible. They use a lot of anticonvulsants. So they use Depakote, they use topiramate, they use alpha-2 agonists like clonidine or lofexidine to treat the sympathetic hyperarousal. And apparently it does well. And the rationale for that is why stop alcohol and give them a synthetic alcohol, and you also have a risk of putting them and making them, addicted to benzodiazepines. All right. So the rationale there is the danger is seizures. So if you treat it with you load it with an anticonvulsant and you treat the hyperarousal with alpha-2 agonists, it's another way of treating the patient without using benzos. But I've never done it. Most people still use benzos. All right. These are different treatments for alcohol use disorder. All right. Remember, I know the book, there was a mistype there. I got a lot of emails. So no, naltrexone is long acting. The book said naloxone was long acting. That's not correct. Right. Naltrexone, Trek, is long acting. That comes in injectable form. And that's usually what we use for long-term treatment of alcohol use disorder. All right. Naloxone is not used for alcohol use, but it's used for obviously opioid intoxication. No, I'm sorry, benzodiazepines. No, opioids. Sorry. If someone overdoses on opioids, you can give them naloxone. See, my lack of sleep is affecting me now. Acamprosate obviously is works on GABA. It also helps with alcohol cravings. And disulfiram, we don't use it as much anymore because, as you guys mentioned, if someone drinks a lot and uses disulfiram, they can have like medical issues too. So the disulfiram is also contraindicated in patients who have a history of psychosis. Why? Why is disulfiram contraindicated in psychosis?
Does it work on the mesolimbic system also? Increases dopamine?
It does. So remember, dopamine is converted to norepinephrine, right? And disulfiram inhibits that enzyme that converts dopamine to norepinephrine. It's called DBH, which is dopamine beta hydroxylase. So when you inhibit that enzyme that converts dopamine to norepinephrine, you're going to have way more dopamine that's kind of like there in the synapse, and it can increase your risk of psychosis. So obviously, if it happens in the mesolimbic area, there's a higher likelihood of them developing a psychotic episode. So it's called disulfiram-induced psychosis, and I've seen that before. All right, so make sure you do a good history and you ask them. If you suspect that there might be, just use something else.
Why?
All right, question? This is a PET scan. Yep, question?
I think someone's mic is on.
Oh, okay. Please mute if you don't have a question. Healthy, this is just a good visualization of upregulation and downregulation. So this is actually the dopamine receptors with people using methamphetamine, right? Which is a stimulant, which, increases dopamine in the mesolimbic area. So this is actually a PET scan in the mesolimbic area. If you look at chronic use, the red is actually the dopamine receptors. So look at the middle picture. There's barely any dopamine there. And then after about 14 months of abstinence, it comes back. All right. So it takes a while for the dopamine receptors to come back. Cannabis. All right. For the most part, just know that it's the THC component that's psychomimetic, all right, that causes people to become psychotic. So the higher the concentration of THC to CBD, the higher likelihood of them becoming psychotic, all right? When someone's chronically using marijuana, just make sure you tell them that marijuana inhibits 3A4, 2C9, 2C19. So what's 3A4? 3A4 would be the benzos, right? So if you're giving someone benzos for sleep and they're using marijuana, what's going to happen is they might be overly sedated. You're going to have a hard time actually waking up in the morning, okay? Or have more memory loss or amnesia. 3A4 is also allowed the neuroantipsychotics, right? Vraylar is a 3A4 medication. Latuda is a 3A4 medication. Quetiapine partially uses 3A4. And believe it or not, clozapine is also partially metabolized by 3A4. So if someone's clozapine level is like 800 or 900, and they take marijuana, it might push it over the edge and they might have clozapine toxicity. So just be careful. 2C9 is Depakote, and 2C19 is Lexapro, Celexa, and sertraline, just off the top of my head. All right. All right. Discuss the scheduling of controlled substances. Remember, schedule 2 is your stimulants. Schedule 4 is your benzodiazepines. Identifying the presenting characteristics of sleep-wake disorder. So, just know that a lot of times that, like, if someone is not getting enough sleep, that predisposes them to insomnia. I'm not going to go into details about, obviously this class isn't about diagnosing, so I'm not going to ask you about advanced sleep phase disorder or early phase sleep disorder. That'll be later on in clinicals. Just have a basic understanding of how the different factors play into the sleep drive, circadian drive, right, homeostatic drive, how they kind of play along with each other, and understand how the ARAS, ascending reticular activating system, works, right? How if you block any of those projections, you can cause issues, with arousal. Stahl actually has a good example of it where it has the arousal spectrum, if you guys remember that. So actually too much arousal can actually lead to psychosis. So right before psychosis, you have panic attacks or panic disorder, right? Too much activation can lead to psychosis eventually, right? Hallucinogens, just know that's, so how do hallucinogens work? Anyone know? What receptor does it innervate? Which serotonin receptor? 5-HT2A, right? Okay, so if someone actually is psychotic because they're, you know that they use a psychedelic, I probably won't give them a D2 blocker. I would probably use a medication that has a very strong 5-HT2A antagonist. You probably could give them a D2 antagonist, but maybe use olanzapine because it's both 5-HT2A antagonist and a D2 antagonist. If we just use Haldol, it might not be effective because it's not a, 5-HT2A is what's causing the psychosis. And that's 5-HT2A that's on the GABA interneuron, right? That downstream will actually increase dopamine. Okay, so you want to really stop those. All right, so you have mushrooms, you have ayahuasca, you have ketamine, there's a bunch of them now. Okay. Discuss the pharmacology of cannabinoids. Yeah, question?
Yeah, do they all work by the serotonin?
Yes, they're all very potent 5-HT2A
The VMAT.
agonist, 5-HT2A agonist.
So they reverse the pump and they go into the VMAT into the vesicles and release the serotonin.
No. You're talking about how psychedelic hallucinogens work?
Yeah.
No, what they do is they are agonists to the 5-HT2A receptors, which are actually excitatory on a GABA interneuron. But that GABA interneuron is actually linked to a glutamate neuron, which also linked to the ventral tegmental area, the mesolimbic area. So if you think about it slowly, what happens if you I might be confusing you guys. Yeah, take that back. For now, I'm not going to ask you that question. Just know that 5-HT2A agonism on a GABA interneuron is going to work downstream with the VTA and increase dopamine firing and cause psychosis. All right. Sorry, I'm running on 4 hours of sleep right now, so I want to make sure I tell you guys things that are accurate. And it's hard for me to visualize and explain it, but just know 5-HT2A agonist downstream will cause increased dopamine in the VTA, all right, in the mesolimbic area. And you need to give them a 5-HT2A antagonist. What medication do we have that's just a 5-HT2A antagonist? Do you guys know? Use it in Parkinson's psychosis. It's the only medication that's FDA approved for Parkinson's psychosis. Starts with a P. Pimavanserin. Right? It's a 5-HT2A antagonist only. For whatever reason, in Parkinson's psychosis, there's upregulation of serotonin receptors. So there's so much 5-HT2A serotonin receptors that they're upregulated. So we're actually blocking those receptors, and then downstream it reduces dopamine in the mesolimbic area. All right. Why don't you want to just block dopamine in Parkinson's? Because it's going to worsen movement disorders. So you're actually improving psychosis not by blocking dopamine, but blocking the 5-HT2A receptors that are upregulated. All right. It has to do with the connection of the dorsal raphe to the mesolimbic area. All right. Some of the connections die down from dorsal raphe, which was what secretes serotonin. So what happens when those connections die down? What happens to the postsynaptic neuron? If the connections die down, not enough serotonin goes up, right? So what's that postsynaptic neuron going to do? It's going to upregulate and become more sensitive. So by upregulating and becoming more sensitive, that's what's going to cause psychosis downstream in the mesolimbic area. All right. Just know that cannabinoids we do have naturally occurring endocannabinoids in our body, right? One of them is an anandamide, and those are what? Retrograde neurotransmission. It goes from the postsynaptic to presynaptic, all right? Just know that naturally they're not full agonists. They're like partial agonists in a way. So when someone actually uses cannabinoids, your body's getting a full agonist that it's not used to. So a lot of that can cause issues with, obviously, the cannabinoid system interacts with a lot of our other systems in our brain, right? Serotonin, dopamine, norepinephrine, it can cause all those symptoms, okay? Nicotine dependence, just know the treatment. Obviously, you have nicotine replacement therapy, right? You have the patch, you have the gum. You can use meds also. So you have bupropion, right? Which is a dopamine norepinephrine reuptake inhibitor. So what you're doing is you're giving someone just enough dopamine so that you're stimulating that receptor in the reward pathway, so the person is not craving nicotine. Okay, and you also have Chantix, which works in the A4B2 receptor. The A4B2 is a nicotinic receptor that when it's stimulated, it actually downstream increases dopamine also. So by giving them an A4B2 nicotinic partial agonist, you're giving them just enough stimulation so that they're not craving the nicotine. Does that make sense? Okay. We don't have any medicines right now that are FDA approved for stimulant use disorders like amphetamines, but there's some pretty positive studies right now using Vraylar for amphetamine use disorder. Using what I just told you guys about the A4B2 with nicotine, which is a partial agonist, how can Vraylar actually help with substance use disorder when it comes to amphetamines? Why do you think it works? It's a dopamine partial agonist, right? So by innervating that dopamine receptor just a little bit as a partial agonist, you're giving it that little bit of stimulation so someone's not craving a large dose of methamphetamine. All right. Any questions? Remember, the final is going to be cumulative, so there's going to be a lot of questions from the first midterm also. So make sure you don't get those same questions wrong.
I have a question.
Yes.
When you, I thought the five, I'm just going back to the hallucinogen and being a 5-HT2A agonist, and I thought that the 5-HT2A was like a dopamine break. No.
Yes and no. It depends on where it's connecting. That's the thing. It's like it's very hard to make blanket statements like that, depending on what part of the dopamine pathway it is. All right. I don't have time to break it down, but I promise you, if you're with me in clinicals, in the next semester, I'll draw it out and show it to you.
Okay.
For right now, yeah, when it comes to substance abuse, for now, just know 5-HT2A agonism causes psychosis.
Okay.
For now.
Yep, I gotcha. Okay.
That's why a lot of our antipsychotic meds are 5-HT2A antagonists. Because I can actually say it. All right. So not in the mesolimbic area. That's in the movement area and the mesocortical area. So if it's a break in that area, that's why when you give someone a 5-HT2A antagonist, it's only increasing dopamine in those two pathways. It's not worsening psychosis. It's actually improving EPS and it's improving cognition because it's only in those two pathways. Does that make sense?
Yes.
Okay. All right. So not in the mesolimbic area, only in the mesocortical, nigrostriatal, and tuberoinfundibular.
Okay. Thank you.
All right.
Yep.
Any other questions?
I have a question, Professor Collado.
Yes.
Can you talk about the Naloxone challenge, please?
Naloxone challenge pertaining to what?
When Professor Smith put the message about Naloxone and Naltrexone, he said that Naloxone is FDA approved for the opioid use disorder, Naloxone challenge, as well as opioid overdose. Can you explain to me what Naloxone challenge is about? I have no idea.
Let me see. I've actually never heard of Naloxone challenge. I've never heard of that before. Let me see the email just so I can kind of see. 1 second.
Thank
I
you.
know the email that he sent was because there was a lot of confusion because the book was wrong and it labeled naloxone as a long-acting opioid antagonist, but it's not. And it said naltrexone was a short-acting, which is not. And it said something like, that's what we use naltrexone for acute opioid overdose, and we don't do that. So I think that's why he sent the email, but let me see. I've never used a naloxone challenge, but I'm curious to see what it is. Let's see.
Yeah, I was reading about it, and it says that you give the naloxone, it can be IM, and you have to check for signs and symptoms of withdrawal. If there's no withdrawal, no more naloxone, something like that. But so I'm confused at this point.
Yeah.
Thank you.
I'm familiar with this, but I didn't call it the naloxone challenge. So I guess I'm assuming that the naloxone challenge means that if someone comes into the hospital, right, intoxicated with opioids, you don't know what the half-life of the opioid is, right? The danger is that you give them naloxone, which is short-acting, and then you leave them, you give them the medication, they're fine. Then all of a sudden, the naloxone half-life is much shorter than the half-life of the opioid, and the person goes back into intoxication again, right? And respiratory, depression. So the naloxone challenge, I'm assuming, is that you have to find out exactly how much you give them, because then you're going to have to figure out when am I going to put this person on a longer acting eventually to make sure that they stay stable and they're not going to go back into respiratory depression. Does that make sense?
Yes, maybe naloxone is the Narcan, the rest.
Yeah, naloxone is Narcan. Exactly, naloxone is Narcan. Same thing. Yep, naloxone is
okay.
Narcan. Yeah.
Okay.
But is naltrexone, which is the preferred? Naltrexone is preferred. Is the preferred antagonist if someone were to come in, and you wanted to reverse it on opiates?
No, naloxone ox is what you're going to use acutely. Naltrexone, you would only use naltrexone if someone is already stable and they need something that's going to keep them from relapsing again.
Okay,
right? So
okay, because that's I thought that was the way it was, and then I thought that the message was saying something different. So okay.
No. You had it correct the first time. The book was wrong. Yeah.
Okay.
This is the last time I'm not using this book. If I'm teaching again next semester, I'm not using this book.
Okay.
Yeah, that was wrong. Naloxone is short acting, used for acute symptoms. Naltrexone was used for prevent and maintenance. Right.
That's okay. That's what I thought. Okay. Thank you.
That's correct. Yeah. Yeah. The book had it wrong. Sorry for the confusion.
Can you explain how alcohol increases dopamine?
Yeah,
uh,
let me go back to that slide. So you see the ventral tegmental area, it's not showing the nucleus accumbens on the top, but it's projecting upwards, all right? Now you see the arcuate nucleus there, the opioid neuron, okay? That's what secretes endogenous opioids, which brings pleasure, all right? So normally, when something feels good, it's gonna secrete that there, and it's gonna hit the dopamine neuron, which causes pleasure, right? When you drink synthetic alcohol, it's actually gonna bind to that same opioid receptor. So in a way, alcohol actually is related to opioids, the way that it binds to that receptor. Not as strongly, but it is going to innervate that opioid receptor. And it's not, alcohol, I guess, enough people, it helps a little bit with pain, but it more gives you the euphoric effect. So it's going to hit that dopamine neuron. It's going to cause the dopamine neuron to actually secrete more dopamine to the nucleus accumbens. All right. So alcohol binds to the mu opioid receptor on the VTA, which is a projection of a neuron that goes to the nucleus accumbens.
because the Edinger book doesn't really, it talks about how alcohol really should be inhibiting dopamine in that area.
I have to read that part. I'm not sure how does it
It
inhibit?
says dopamine neurons in the VTA are regulated by a large population of GABA neurons within this region. Increasing GABA activity by alcohol would therefore inhibit dopamine activity in the VTA.
You know what? I'm not going to ask you that question. Considering there's been numerous mistakes in the book, I'm going to have to clarify that because I don't think that's correct either. All right. Just go by what I'm telling you. That dopamine innervates mu opioid receptors. That's the reason why we have all these treatments that work. You give someone a mu opioid antagonist like naltrexone, right? They don't have alcohol cravings.
Because then it works on the mu receptors. It's
Yeah, it works in the mirror. Yeah, it's blocking the receptor that alcohol would bind to. So it's not going to cause that reinforcement from the VTA to actually secrete dopamine to the nucleus accumbens. All right.
Professor, can you go over the mechanism of action of the naltrexone?
Naltrexone? Yeah, so naltrexone was a long-acting mu opioid antagonist. All right. I believe it blocks mu and delta. It blocks those. And then what happens is those are the receptors that when they're innervated by opioids that cause the euphoric effect, the respiratory depression, the downside is that it also blocks the pain, the analgesic effect of it. So if someone needs it for analgesia, it's not going to work. Now, naltrexone also has a really bad side effect that a lot of people don't really emphasize. So what happens when you block the mu opioid receptor chronically for a long time? People lose the ability to feel pleasure. So people who are actually on naltrexone for a long time, even though they're abstinent from alcohol, they kind of have this persistent depression that never gets better, even if you give them, antidepressants, right? It's kind of like a chronic anhedonia. And also they're also very sensitive to pain. So little things that might not, because normally our bodies, like let's say for instance, if I tap you, right? Your body is not feeling that as pain because your arcuate nucleus is secreting endogenous opioids to kind of suppress that, right? So that's why when your shirt is touching your skin, you're not in pain. But when that pathway is broken down, people are actually more sensitive. So little things that that weren't painful before can actually be painful now. So I usually always counsel patients, look, naltrexone is great. It's going to help you, stay away from those substances, but just know that these could be, some of the long-term risks of it, right? You might have this chronic anhedonia, but the issue is too, chronic alcohol use also causes something called protracted alcohol withdrawal syndrome, which is kind of like a persistent depression also from alcohol use. And that's also very hard to treat. All right. That's kind of being investigated now. How do we treat it? All right. So increased pain response and chronic anhedonia are some of the side effects of blocking the opioid receptor long-term chronically. Does that make sense?
Yes.
We also use naltrexone, remember, for skin picking disorder, trichotillomania, kids who injure themselves off-label, obviously, but there's evidence behind it. So head banging, we use naltrexone also, skin picking, hair pulling, anything that's kind of like impulsive. And I think there are also some studies that show that naltrexone also helps with like kleptomania. Remember, something that's impulsive over time, when you keep doing it, it becomes compulsive, right? Impulsive is like you want to get high, you use it. Compulsive, it's almost like you're doing it and it goes to your striatum, right? It goes to your dorsal striatum, the motor pathway. So it's almost like a routine. You don't even think about it anymore. You're just doing it as a reflex.
So it can also be effective for gambling and binge eating also?
In theory, yes, but I don't know off the top of my head if the studies actually show that.
Okay.
You know, it's funny, be careful too with partial agonists, all right, and stimulating dopamine receptors. So if someone has Parkinson's, you're giving them like amantadine or you're giving them anything that's a dopamine agonist, it actually can increase, it makes them like some of them, they can become impulsive gamblers, compulsive gamblers. Some of them like start developing like really risky sexual behaviors. They become very like pleasure seeking. So if you give someone, dopamine, that can happen. And also if you give them a partial agonist, that's why Abilify aripiprazole also has a box warning. It's at the box warning, I believe it can increase risk of impulsive or compulsive gambling. So if you start seeing patients, doing things that they weren't doing before, make sure that it's not the medication that's doing it. All right. Any partial agonist. Right now, Abilify has that warning, but anything like brexpiprazole partial agonist, Vraylar, cariprazine partial agonist has that risk also. All right. Because sometimes, remember, there's not going to be enough dopamine there. It's going to innervate it. And sometimes you innervate it too strongly, it can cause a rewarding effect, which is not good. And people might do things riskier.
How would you treat the gambling addiction?
I would switch the meds. I would stop. I would not use the partial agonist. That's what it's happened to me in the past. And I would switch them to if it's for schizophrenia, I would switch them to a full D2 antagonist. There's actually case reports that if you combine a partial agonist with Wellbutrin, there's a higher risk of it as well. Because remember, dopamine, Wellbutrin is dopamine norepinephrine reuptake inhibitor. It's increasing dopamine in the synaptic cleft, and you're also giving a partial agonist at the same time. So just be careful. That gives it a higher risk. But that's case reports. But just be careful. See why it's important to really understand the mechanism of the meds, because when patients come to you and they mention these symptoms and you see the meds are on, you have to be able to conceptualize, okay, maybe it's secondary to the medication that you're prescribed by your last prescriber, right? Not that, okay, now you need naltrexone because you have a compulsive disorder, and then you're adding meds and then you start using polypharmacy when you can just kind of, sometimes less is more. So before you would add meds, I would look at the regimen that they're on now and see if the regimen is interacting in a way that's actually causing their symptoms or worsening the symptoms. Any other questions? I finished this quick, actually. I did this in like 20 minutes. Wow, they give us a lot of time for review.
Can you talk about ADHD and ADD?
Sure. What about it in particular?
I'm just not grasping it. Like the stimulants, what they do. I'm just not getting the full grasp.
So, ADHD is conceptualized. It used to be conceptualized as like a deficiency of like not having enough norepinephrine dopamine. But in reality, I think Stahl mentioned it's the best. It's kind of like tuning the brain. So sometimes, it could be due to too much norepinephrine, too much dopamine, because also remember that spectrum that he shows. If you have too much, you might have to go down a little bit, right? So not everyone that has ADHD is going to do well on a stimulant, and that shows, right? I think maybe 60 to 70% will respond to a stimulant, but there's still like 30 to 40% that don't respond to a stimulant. And you have to give them an alpha-2 agonist. It's hard to know which patients will respond to which. So depending on comorbidities, you might have to kind of like, if someone has like a history of aggression or like maybe, cognitive disorder, I might not actually use a stimulant I might not use Adderall, because we know Adderall can sometimes increase aggression and aggressive behaviors. Maybe I would lean more on an alpha-2 agonist first. Right? If kid doesn't have a history of aggression and there's no family history of substance abuse, then maybe I'll feel more comfortable using maybe methylphenidate. We use methylphenidate more, and actually a lot of studies show that methylphenidate tends to be more effective in kids for whatever reason, and amphetamines tend to be more effective in adults. We don't really know the reason why, but I lean more in methylphenidates. They tend to be more safer, because remember, it's not as potent. It doesn't reverse the VMAT like amphetamines do. All right, so ADHD is a dysfunction in dopamine and norepinephrine, not necessarily not enough, but it's tuning. So you kind of have to play around. You might have to increase norepinephrine and see how the patient responds. Cognition, attention, sustained attention, usually is a dopamine issue. So most of the time, you probably will have to increase dopamine some way. If you're afraid to do it using a full stimulant, you might use a norepinephrine reuptake inhibitor, because remember, it's still going to increase dopamine, not in a strong way, because you don't have dopamine transport pumps in your frontal lobe, right? Remember, norepinephrine transport pumps are what brings dopamine up. So by blocking norepinephrine transport pumps, right, you're actually increasing dopamine in the synapse in the frontal lobe, because it's that actually keeps dopamine there. Does that make sense? But it's not giving it that strong punch that a methylphenidate or an amphetamine is going to do. It's still a little bit safer. But remember, it's not going to work as quickly, so you have to tell the patient it might take 2 to 4 weeks for the Strattera or the Viloxazine quality to work or kick in. But it's safer, less risk of inducing mania, less risk of causing psychosis, less risk of causing aggression. It might not affect appetite as much. It's not going to cause insomnia, right? Did I answer your question, Jessica?
Yes.
Yeah.
Professor, I have a question. When it comes to ADHD medications, we had like a couple tables posted online, I mean, on the Bright side and included in your lecture. Do we need to know like the very exact doses and?
No, I'm not going to ask you about doses, but know the difference between methylphenidate and amphetamines, and know the difference between an ER formulation and an IR formulation.
Okay, and that would be sufficient. And like hours, how many hours? Because each one is like so specific. It's like somewhere.
No, I'm not. Yeah,
10 and
I
12.
don't even have it memorized, so I don't expect you guys.
Okay, and same thing when we talk about sleep and we talk about.
Well, I'm sorry. Going back to ADHD before my train of thought. Know that there's a food interaction with amphetamines. What is it? A food or not just food, but there's an interaction with diet in amphetamines. What is it?
Is it?
Amphetamines you have to take on an empty stomach.
Close.
Or because citric acid.
Yes, acid. Yes, acid.
Yeah.
So the more acidic you make the stomach, right? Whether it's from diet or from taking, vitamins like ascorbic acid, vitamin C, it's going to increase the secretion of the amphetamine, because remember, amphetamine is a weak base. So if a patient all of a sudden, is taking the same dose of Adderall, which is amphetamine, and it stops working, I would speak to the patient and say, hey, were there any changes in your diet? Or are you taking a lot of vitamin C? Most of the time it's vitamin C. I'm drinking a lot more orange juice now. I'm drinking a lot of other citrusy stuff that's vitamin C. Then I would say, okay, we have an option. Either you change your diet or we put you in methylphenidate, because methylphenidate is not affected by that.
Can you just repeat one part, because I'm taking notes?
Yes.
So you said the food
amphetamines are affected by the acidity of your stomach. So
you
anything that makes your stomach acid will actually increase the excretion of amphetamines.
Oh, that's it. Okay. That's the word I missed.
Right? So anything that makes your stomach more acidic. And most of the time it's vitamin C. That's what I see in clinical practice most of the time.
And can we now mention the sleep medications? So Stallbook and all the books, basically same thing with NIE. There is so many different meds. Most of them.
Okay, I'll know the different classes. So obviously antihistamines, right? Because remember, histamine is what keeps you awake. So you have histamine projections from the basal forebrain that hits your cortex that keeps you awake. So if you give someone an antihistamine and you block those receptors, it's going to cause someone to be tired, right? Antihistamines. You also have, blocking serotonin, blocking dopamine, blocking acetylcholine. That also can cause people to get drowsy also, all right? Orexin is another neurotransmitter that's also there to help you stay awake, right? That's part of the wake drive. So anything called orexin antagonist, when you block orexin, or hypocretin, HYPOCRETIN is another name for it. So orexin or hypocretin antagonist. And those meds are usually suvorexin is one, and lemborexin. Well, those are the two main ones.
What about
That's the name
those?
of the meds, but just know orexin antagonist will help people fall asleep. Okay. And if you want to keep someone awake, if they have narcolepsy, which we don't really treat that in psych, but we use meds that increase histamine. What's a medication that increases histamine? Modafinil. Modafinil is a histamine agonist, and it's also a weak dopamine transport blocker. So it works on that, similar to stimulants, but not as strongly, and it increases histamine. That's how it keeps people alert.
Can you please repeat that name, Professor? The name of the medication that keeps us awake?
Modafinil, M-O-D-A-F-I, M-O-D-A-F-A-N-I-L,
Thank you.
modafinil. I use modafinil sometimes if patients are on like high dose of clozapine and they're sedated and they can't like stay awake. So I'll use modafinil, or the isomer armodafinil, or I use Concerta.
And what is that for dopamine? Dopamine
That'll
blocker?
keep them alert. That'll keep them awake, so they're not so drowsy from the antipsychotic medication. So it's off label, obviously. That's just, I'm not going to test you on that, but just something to keep aware. That's the thing. Once you understand the mechanisms of the meds and how they work, you're free to kind of like prescribe meds in your own way, right? I'll give you an example. Vibrid. Anyone heard of Vilazodone before? Vibrid? It's generic now. Vibrid was a medication that was, they were kept saying, well, it's going to be better than SSRIs because not only does it work in the serotonin transport pump, right? It's also a 5-HT1A partial agonist. But guess what? No one prescribed it because the people that were like, like me, like you don't want to do a pre-authorization. So instead of giving someone Vibrid, I can make my own Vibrid in a way. I can give them an SSRI like, sertraline or Lexapro and give them Buspar, which is a 5-HT1A partial agonist. I don't have to do pre-authorization, right? The downside is the patient has to take 2 medications, but you're kind of giving them that same mechanism of action without actually having to do PA and having to do a higher copay. Any other questions? You can ask me about anything that we covered. Remember, we have schizophrenia, we have bipolar disorder, we have depression, we have anxiety, substance abuse, sleep, ADHD. It's a lot of topics.
I have a question on the CYP inhibitors. There's a big chart. How do you want us to focus on that? Should we just memorize some of the main meds that we see and how they affect some of the big names? Is that kind of what you suggest?
Definitely know, the BFP drugs, right? Bupropion, fluoxetine, paroxetine. Those are antidepressants that we use, and those are CYP inhibitors. Chamomile tea is a 3A4 inhibitor. What else should you know? Obviously, marijuana. Everyone's smoking weed. That's a 3A4, 2C9, 2C19 inhibitor. But those are the main ones.
Can you go over BFP again? Bupropion.
BFP. Bupropion, Wellbutrin, fluoxetine, which is Prozac, and paroxetine, which is Paxil.
Thank you.
The most significant one is actually fluoxetine. Why? Why is the fluoxetine interaction the most significant?
Is it because it has the longest half-life?
Very good. Yes, it's a long half-life, so it'll stay there, and it'll inhibit all the other meds that they take for that next month.
Professor Collado.
Yes. Oh, also remember, inhibition works instantly, right? So if someone takes a medication that's an inhibitor, it's going to affect all the other meds that they get put on right away. If you give someone an inducer, it takes a while for your liver or your small intestine to make those CYP enzymes. So it might take a week for it to work. So if you give someone an inducer, you're not going to notice that induction right away until a week later, 7 to 10 days. All right. If you give someone an inhibitor, it's going to inhibit everything right away. So remember, inhibition is fast, induction is slow. That's why carbamazepine, when you give someone carbamazepine, it induces its own metabolism. You have to check its level again a week after, because whatever that level was in the beginning, it's gonna be much lower than it was before, because it induces its own metabolism. So induction is slow, takes about a week to 10 days. Inhibition goes right away. Which is why the opposite too. If someone is taking an inducer, right, and then they stop the inducer, it's gonna take a while for that effect to happen again. All right, so let's say for instance, they're smoking, which is an inducer of 1A2. You might not notice the drastic increase in clozapine until a week later on. So inhibition right away. Induction is slow. Does that make sense? Is that clear?
Yeah, I read something today about like if somebody's on Zyprexa and they smoke, you have to lower the dose of Zyprexa.
You can, because Zyprexa is metabolized partially by 1A2. So Zyprexa is actually metabolized by 1A2, 3, 4, and 2D6. But it's not as significant as clozapine, because clozapine can cause, severe neutropenia, constipation, myocarditis. So the risk of increasing olanzapine is not as dangerous as of increasing the clozapine. But yes, you do.
So that would apply to both drugs, like it would apply to Clozaril and Zyprexa?
Yeah, I would. But you know what? I use high dose olanzapine pretty regularly because I treat very psychotic patients. And believe it or not, if someone doesn't want to take clozapine, the next best medication is actually high dose olanzapine, which is like 30 milligrams or higher. So I have some patients with 40 milligrams of olanzapine. So on average, so when you give someone their first antipsychotic, right? Just an idea, give or take, 80% of people in the first episode will respond to any antipsychotic given. You can give them Haldol, Thorazine, olanzapine, you name it, Latuda, 80% will respond, right? If they don't respond to that, the second is less than 10%, right? After that, their third medication, if you don't give them clozapine, right, which is a 50 to 60% chance of responding, their chance of responding is less than 5% on any other antipsychotic. Does that make sense? So first trial, they have an 80% chance of responding. If they don't respond to that, the second trial of an antipsychotic is less than 10%. All right. If you go to a third med that's not clozapine, it's less than 5%. If you use high dose olanzapine, it's 7 to 8%. It's still not great, but at least it's better than less than 5% or 2% or 3%, which is almost like zero. So high dose olanzapine, I use pretty successfully for patients who don't want to go on clozapine for whatever reason. They hate needles. They read about it. They're afraid about it. So I use the next best thing. I push up the olanzapine, and you can actually put patient. There's reports out there actually that olanzapine in forensic settings, people. So olanzapine level normally is double the daily dose, right? I think I told you guys that before. So if someone's like olanzapine 40 milligrams, which I have some patients on, I do a level, give or take, it's around 80 nanograms per ml. Right. So in a forensic setting, if you have patients stable on 150, that means that they're giving them 75 milligrams of olanzapine, and those patients are fine. They're okay. So, to answer your question, Jessica, even if like they're on 20 milligrams of olanzapine and they take an inhibitor and increases it, it's not going to kill them. It might just make them a little bit more sedated. But if you do that with clozapine, it's really dangerous.
So I have a question, maybe like help us better understand. Like we have a young patient right now. Of course, I'm not going to give up.
Where do you work now, Jessica? What hospital is that?
South Oaks.
Oh no, South Oaks.
Don't say that. I'm the director there.
I had a big argument with one of the providers. I'm not going to say his name, but I don't know.
You can tell me offline. I'll probably agree. Anyway, we have a patient. So this patient is not responding. It's a young patient. So the doctor was talking to me today that we started her on Haldol deck and we're waiting for the window to kick in. So in the meantime, we're loading her. But I feel like the patient's getting worse. So we keep meeting about her. We keep having discussions. But he talked to me today about Haldol plateauing. So, but we didn't get to circle back. Like what would make Haldol plateau?
What does he mean by plateauing? I don't know. What does he mean by that term? I don't know.
He's saying like it could plateau. So like the patient, like we could keep giving her more. And he doesn't know if it's necessarily going to make a difference because she might have just plateaued.
Okay, so plateau, I understand. There's a point in which the medicine is not going to work anymore, right? So plateau, I guess, means it's like it's futile to actually go up any higher because it's not going to do anything. It's just going to cause side effects. In reality, right, there's really only one way to treat psychosis, right? Whether it's blocking dopamine or using clozapine, that's it. There's no other way to treat psychosis, right? Some people don't understand that. And the people who treat schizophrenia all the time, like me and other specialists that I work with, we understand that. And the reason why I really emphasize that is because if someone is not responding to a dopamine blockade for psychosis, please don't put them on a dopamine blocker. You're really wasting their time and you're causing them more misery. The example I'm going to use, Jessica, I'm not going to give the name, but I had a patient that I was treating for psychosis, and the mom brought them to the hospital, right? South Oaks, whatever. And what happened was I did a risperidone level, and the patient was already on the highest end of risperidone. So I knew in my mind that dopamine blockade was not going to work anymore. He was on olanzapine, caused him to gain weight. We used risperidone. He was okay for a bit. Then what happened was mom had stopped the risperidone, but then for whatever reason, when you stop the meds, sometimes it doesn't work again. We don't know the exact mechanisms to why it doesn't happen, but I always tell patients, if the med works, please stay on it, because if you stop it, there's a possibility it might not work for you again, right? So I did a risperidone level just to make sure he was taking it. So risperidone usually is 7 times the daily dose. So I had him on like 5 milligrams or 6 milligrams of risperidone, which is already high. And it was like in the 40s, the level. So I already knew that he was taking the medication and it wasn't working. So I spoke to the parents and I said, look, I want your son to get hospitalized because I want to start him on clozapine. And I feel like right now, it might be hard to do weekly blood work. And also I want to make sure he's medically cleared. I want to do EKGs on him, do all the blood work to make sure. And I said, once they can stabilize him on the clozapine, I can manage it outpatient, right? And also the mom was a little finicky. I had a feeling that mom might not give him them because mom already had like not given him the meds a few times when he was 17 and now he's 18. So they admitted him to South Oaks, and I even gave a good report to the prescriber. I said, look, please put this patient on clozapine because I gave him I showed him the olanzapine, I showed him the level of olanzapine, I showed him the risperidone, I gave him the levels of risperidone. Doesn't contact me for a couple of weeks. So I'm like, all right, what's going on here? So I had the social worker check in, and then the parents talked to me. They say, oh no, they put him on Abilify. And I said, Abilify? I said, that's like a waste of time. I said, I already had him on olanzapine. I had him on risperidone. Why would you put someone on a partial agonist? Of course, the patient became aggressive and was like fist fighting a patient on the unit. So then they put him on loxapine, and I was like, okay. So I was like, now they're just trying different meds, which isn't working. So I got pissed off. So we had a meeting. It was my team and his team. And I said, look, I showed you the levels. I said, what's the reason for not starting clozapine? It's not like I gave you a verbal and said he was on this, so you had to actually try the medicines and then you can do clozapine, right? He was like, well, it's a medication and that can cause all these. I said, yes, it can cause all these side, but you guys are an inpatient, and the reason why I had him hospitalized was to start him on clozapine. Guess what? They held him for almost 2 months, discharged him on clozapine, and now he's better. But they tortured the kid for like a month to finally put him on the medication, and he was like unstable. So, I mean, the moral of the story is, if someone is not responding to dopamine blocker, please put them on clozapine. If not, high dose olanzapine, and explain to the patient, this is the only thing that's going to work. We do see patients that respond to risperidone and they were on olanzapine. And why is that? Tell me. Why is it that you tried olanzapine, which is a dopamine blocker, but they respond to risperidone? Is it because of dopamine blockade? Tell me.
The serotonin blockade?
No, it's not. It's actually just a pharmacokinetic issue. That's what I keep trying to explain to everybody. If someone is responding to risperidone, right, but they're not responding to olanzapine, maybe they're a 1A2 fast metabolizer, right, and they're in their regular metabolizer of 2D6 with risperidone. Therefore, they're actually going to work. Risperidone is going to work for them. You're not going to know that unless you do a level. So the best thing to avoid all that is just do a level. Then you'll know the medication. So if you do a level and a strong D2 blocker, and it's accurate and it's actually the same dose of the level, the new guidelines actually don't even wait 2 trials to do clozapine. Do clozapine on the second trial right away, because we know that blocking dopamine is not going to work for them.
So that leads me to like my next question. So that case I was talking about, this child was stable.
Haldol dopamine blockade is already out the picture. So
no, that's not what I was going to ask. So this child was stable on the outside, and the psychiatrist stopped the Haldol because she had a remission of symptoms, which makes no sense to us. Now we can't catch up with this child. So now he's thinking, the psychiatrist is actually thinking now that the Haldol might not work, and we're probably going to have to go to Clozaril. But why would that mechanism? So like if Haldol worked for them, then they stopped taking it for a while, became psychotic again, and now why wouldn't the Haldol work again?
Because your brain is very smart, right? It all has to do with desensitization, upregulation, downregulation. So when you take the med, what happens, your brain will try to move in a way, manipulate in a way that kind of counteracts it, right? Kind of like homeostasis. So if someone stops the medication, it's almost like the best analogy I can give is like antibiotics, right? Antibiotic resistance, very similar to antipsychotic medication. Sometimes we really push for long-acting injectables, because if someone's a long-acting injectable, their adherence is pretty constant, right? The brain is getting a constant dose of that medication all the time. There's no peaks and troughs, and it's always staying. And people stay well for decades sometimes, or a long time. Once you start going to PO and people have history of non-adherence, there's always a risk that either I have to raise, let's say for instance, they were stable on Haldol 10 milligrams, right? We go back on 10 and they're still psychotic. Then I push it up to 15 and they're stable again. Then what happens? They stop again. Now the next time they come back in the hospital, then I go to 20, right? Then at that point, it's futile, right? I guess he hits that, what do you say? It's a plateau, whatever you want to call it. You can't use it anymore. It doesn't work. So that's why I tell patients sometimes if a medicine works in your first try, you're lucky because not everyone is lucky getting the first med to work the first time. Stay on it. So that you want to maximize the use of that medication as long as you can, because we don't have many different mechanisms to treat psychosis or schizophrenia. You really only have like, partial agonist. That's why like the way I do it is I'll do a partial agonist first because a partial agonist is usually not as strong dopamine blockade. It's more tolerable. If the partial agonist doesn't work, then I use a D2 antagonist. If the D2 antagonist doesn't work, then I already know going back to partial agonist is a waste of time, right? Because we already tried that. Go right to clozapine. Or same concept. If someone's already tasted a D2 antagonist and it doesn't work and you do a level, there's no reason to go to a partial agonist because you already know D2 antagonist is not going to work. What's a partial agonist? Remember, it maxes out at like, 80%. It can't go up to like 90 or 95% dopamine blockade. It's maxed out at that point. So why even go down? It's not going to work. Have you ever seen a patient not respond to Risperidone and olanzapine and respond to Abilify? I've never seen it.
I get what you're saying now. So you start off, you ideally.
Yeah, you walk. Yeah, it's a step progress because you always want to use the most benign drug because it's usually those most tolerable drugs. Less weight gain, less sedation, less EPS, and then you climb up the ladder. Yes, Alex.
Okay. So for a dystonic reaction, I see two options to treat dystonic reactions. One is cogentin, and another one is Benadryl. I guess my question is Benadryl. How you call it? It's a black. I forgot.
Use cogentin. Don't use Benadryl unless you want to put the patient to sleep too. The reason why is because all you need is anticholinergic. Benadryl is antihistamine and anticholinergic. You don't need to affect the histamine receptors. So it's actually better to just use cogentin because it's a cleaner medication. Not unless you want the patient to sleep. Let's say like it's bedtime and they have dystonia and it's like 9 o'clock at night. Then sure, give them Benadryl because it'll help them sleep and it'll help the dystonia. But if it's like dystonia at like 9 a.m. in the morning or 10 a.m. in the morning, just give them cogentin. All right. Dose all your antipsychotics. I know it's not done like this, but you should be dosing all your antipsychotics at bedtime. Tell me why. Why do you think antipsychotics should be dosed only at bedtime? Because EPS is when the medication peaks, right? If you're sleeping, your nigrostriatal area is asleep. You're sleeping. You're not going to be moving around in your sleep. You're not going to have dystonia. You just go right to sleep. By the time it peaks, it's 3 a.m. in the morning or 2 a.m. in the morning. Now, unless you're working overnight at Costco, it's not going to matter for you, right? So give all your antipsychotics at night. So it peaks while they're asleep and there's less likelihood of EPS. If you look at a lot of the package inserts for a lot of the medications, I'm going to quote Latuda because that's the most recent one that I'm aware of. If you look at the akathisia rates, actually, for the patients, because in the package insert, it's going to show that patients that were dosed Latuda at bedtime, the akathisia rates were like less than half. Patients who got Latuda in the morning, the akathisia rates were much higher. So for tolerability, always dose it. I know in the hospital, we give it in the morning, right? Which you can, if they're very aggressive, of course, you want to give it to them in the morning. But eventually, when they go to outpatient, you always want to make it simpler. Dose it all at bedtime. Once a day dosing too. There's no reason to do BID dosing. Maybe Geodon, because Geodon has a very short half-life, but all the other meds you can dose once at bedtime. Someone put something in the chat. Can't read it. What does it say? Now you know you have to tell me who the provider is. Yes. I won't say this is recorded, so I'm not going to say it. We'll take this offline. Any other questions?
About the format of the final, like I
Yes.
know you said it was 100 questions, but is it possible to like do a little less because we did the NEI, or at least I speak for myself, and it was hard to sit through 100 questions in one sitting. So
Take a modafinil. It's in the syllabus, so I can't really adjust it because the syllabus
it's in the
is binding
syllabus?
contract for what we're gonna do. So I'm sure if I speak to the dean about it, we're gonna have to follow it. So I'm sorry, yeah, unfortunately, it's too soon. But take it as an advantage. You have a higher likelihood of getting more questions wrong and still be okay.
I have a question. I'm trying to understand like using like a Lexapro, and if somebody's having trouble tolerating a higher dose, would it help at all to split the dose in half? Like say someone's going up to 20 milligrams from say 10, would it make sense to do 10 in the morning and 10 in the evening? Or how does that affect the Lexapro? Are they still getting 20 a day with that kind of thing?
Yeah, they still are. The daily dose, you can split it. I've done that in the past too, especially so if a patient has a neurotic personality or they have very high anxiety and they're like afraid to take the medications, they've already read all the side effects before they even took the medication, they're already having a side effect, right? So what I'll usually do is I say starting dose for Lexapro is usually 5 milligrams. I'll say, you know what, for the first week, break it in half, so that's 2.5, and take it. I know it's not going to do anything, but it's more of like placebo. They're going to take it, they're not going to have side effects, and they're going to gain confidence in taking it again. So in that case, sometimes I might break the 5. If I want them to get the full 5, 2.5 in the morning, 2.5 at night. Because remember, when it peaks usually is when the side effects will happen. So the peaks are not going to be as high. But once it hits steady state, it's still going to be the same potency of the medication. So they're still going to get to the same place. It might just be a little bit slower, but they're still going to have the same effect. Lexapro is a great medication. It's actually one of the few meds that's purely a serotonin reuptake inhibitor. All the other medications affect other neurotransmitters. So for instance, Prozac actually affects norepinephrine, right? Much higher than Effexor actually. So if you give someone Prozac 20 and you give them Effexor that's less than 125 milligrams, Prozac actually hits norepinephrine receptors way more. So unless you're going to really go high on the Effexor, you're better off just giving them an SSRI. All right. Sertraline also affects that. It also affects serotonin and dopamine. So technically, it's a serotonin dopamine reuptake inhibitor. All right. The only real SSRIs are citalopram, Celexa, or escitalopram, Lexapro. Right.
So effects are at doses of 75. They act more like an SSRI.
Some say 75, some say over 100. I would definitely go, if you're just going to give them 37.5 of Effexor, you're barely even touching norepinephrine there.
I have another quick question about, like, again, with the Lexapro and the other medications that have like weight gain as a side effect. Did you have mentioned that sometimes you'll adjunct them with, I can't remember the name, like another medication to, like something to help with the weight loss?
Yeah, I like to use the combination of an SSRI and Wellbutrin because it kind of counteracts it. It counteracts the weight gain and the sexual dysfunction of the SSRI. Plus, it affects, increases energy and drive and focus more, right? So you're kind of giving them, it's all three neurotransmitters: serotonin, dopamine, norepinephrine, the trifecta. So if someone's willing to take both medications, a lot of times people only want one med, and that's the challenge that we have. So usually it's like a parent, right? They'll bring their kid and they'll come to you with like, oh, my kid has issues with attention. My kid has anxiety. My kid has depression. He doesn't want to go to school and he's not sleeping, but I only want you to give him one medication. So then what do? Right? Those are different. We only know from psychopharm, there's many different pathways. What medication you're going to use. So what I do is I'll tell the parent, look, you're giving me many symptoms. Each medication, will target specific symptoms. So you tell me, or I'll speak to the kid, which symptoms are the most impairing, and you target those first. But it's very hard for you want to use monotherapy, obviously, right? But a lot of times you're going to have to use like 2 or 3 medications.
If someone stops their antidepressants, is it the same thing with the antipsychotics where it stops working?
Sometimes, yeah. It happens. So sometimes so the concept of treatment-resistant depression and the concept of treatment-resistant psychosis or schizophrenia, it's either there in the beginning, right? Or it's earned. It's earned in that it's kind of like you're taking all these meds and you're not following through a treatment and your brain develops kind of like a tolerance or an adaptation to it. It doesn't work anymore. So that's why I always try to emphasize with patients, if a medicine works and it's not causing side effects, why not just stay on it?
But doesn't the brain develop tolerance either way to the medication eventually?
Yeah, that's kind of it. There's sometimes yes, sometimes no. It really depends. Ideally, if someone's had their first episode of depression or anxiety, I wean them off the first time, right? But if they keep relapsing and we have a serious conversation, look, maybe low dose therapy might be your best bet, keeping on a low dose. Sure, long-term SSRIs does have a risk of weight gain. It does have something called I forgot the term. It's actually a prolonged sexual dysfunction from SSRIs, believe it or not. And it's accepted in Europe, but it's not accepted here in the States for whatever reason. But that's happened. People go on SSRIs and they get off and they still have sexual dysfunction from it. There's arguments whether it's just all in their head, right? Because they've had sexual dysfunction from the meds, now they're off it, and they're kind of like, it's like performance anxiety, or it's actually a real thing. And actually in Europe, they recognize it as a real thing. So this is something you should tell your patients about also.
Which would be the best medication that you can augment to like contradict, I mean, like contra sexual dysfunction? There was like a lot of questions and answers were very different.
Yeah, so I've used trazodone with good success. I've used Wellbutrin. I've also prescribed, Viagra, obviously. Those are really the 5-HT2A antagonists because they increase dopamine in the areas that the mesolimbic area, not the mesolimbic area, in the mesocortical area. So it helps with like arousal. That can also help. But really, sometimes what I'll do is Wellbutrin. The thing is, if you start Wellbutrin, if someone gets sexual dysfunction from an SSRI, and you start Wellbutrin after it happens already, it's going to take about a month or two for it to kick in. If you start it right away, there's likelihood that it's probably not going to happen because the Wellbutrin's already there. Does that make sense? So I'll tell patients you have an option. There's a higher, so sexual dysfunction with SSRIs is actually very high. It's actually underreported. So whatever the drug companies say, they say it's like 7%. Apparently, I think the last study, I think it was like 70 or like 80%. Apparently, when they really ask people honestly, how many have sexual dysfunction, whether it's like delayed orgasm or issues with arousal or issues with actual erection, it's much higher than that. So why not start Wellbutrin now, give a little bit of dopamine there so it doesn't happen, then waiting for it to happen, then I have to give you Viagra, right? Or you have to wait for it to kick in. But I give patients both options, whichever one they're comfortable with. And most would rather, not have it happen. They'll say, okay, fine, give me Wellbutrin. I don't want that to happen.
So if we give Wellbutrin, is it because we are also like including dopamine and norepinephrine?
Correct. Yeah, you're giving dopamine. Yes.
Dopamine. Okay.
Mostly dopamine. Yeah.
And the SNRIs will not help because it only increases dopamine in the prefrontal cortex.
Yeah, it's a good question. We don't really know the reason why that is, but they've tried that and it still causes sexual dysfunction. Wellbutrin is the only one that doesn't do it. There's some things that in the book you try to like rationalize in clinical practice, but it doesn't translate. That's one of the things.
And I have another question. It's a little complicated. So going over and there was like so many different ways, also in style book, where functions of specific receptors were connected to what do we do when we block the receptor or stimulate the receptor, and also like side effects that are related to. Can you simplify it for us, like systematically in a sense?
If I could simplify it, I could.
Crazy.
I wish I could. You mean like simplify in a way, like how do I remember it?
Yeah.
It's I think over time, as you keep prescribing these medications and you do med teaching with your patients, because a lot of our job is education, right? And you're explaining the side effects, it just becomes ingrained in you. And then as a student, it's hard because you're kind of cramming the material and then you have to regurgitate it for an exam. But once you're in clinical practice and you're kind of seeing it and you're talking to patients, it becomes much easier. Trust me.
It wasn't ingrained in me. I was going crazy.
Yeah, it'll make sense. Just trust the process. Once you get to clinicals and you're like 537, it'll make sense. Philip, are you still there?
Yeah, I'm here.
So is it making sense to you now, considering you've been in the program for a year? Maybe you can give her some insight, give Dorota some insight.
Yeah, it helps. I mean, just repeating it. We've also created like a bunch of like charts for each of the receptors, and that's really helped me, like spreadsheet kind of things. But like I said, he said, like you hear these things so many times over and over and over again that it does eventually become like second nature.
And can we share his spreadsheet?
Yeah, I probably can. Like we're currently working on some right now for serotonin. So yeah, when we finish completing some of them, yeah, we can probably put them up somewhere.
Awesome.
So remember the receptor, depending on if it's presynaptic or postsynaptic, and also depending on what circuit or where it is in the brain, it might act differently also, just to confuse things even more. All right. So sometimes it's hard to make a blanket statement like 5-HT2A, this does that, but it also depends on which circuit and where in the brain it does. All right. But you'll know those exceptions eventually.
Is there a good resource for like algorithm paths for like each diagnosis and which meds with side
I
effects
hate
that you found?
algorithms. I hate algorithms. I'll tell you why. Because the thing is, algorithms give students the false perception that psychiatry is easy, and it's actually not. So when I like, I'll give you an example. Before I got into psych, I was a psych nurse for like over 10 years, right? I was like, oh, it's easy. I'll follow these algorithms. As I kind of started reading more into it, I was like, oh my God, it's actually not that easy, because you can't, the thing is, if you rely on algorithms and people start coming to you from different prescribers and they will, let's say, for instance, this prescriber followed the Harvard algorithm scale, right? This prescriber followed the Florida one. This one followed the one from CanMat, which I like also. Once they come to you and they've tried all these algorithms, what do? Because you want to try an algorithm, but it was taken already. So how do you get this patient better? Unless you actually understand the concepts of it. Okay, this didn't work because they were increasing dopamine. This didn't work because they only gave you dopamine blockers. Maybe clozapine might be the best action, right? This isn't working because you have ADHD and you have insomnia, and you're stable on ADHD with an alpha-2 agonist like clonidine, and this prescriber gave you an alpha-2 antagonist like mirtazapine. I see that a lot, by the way. So someone's stable on an alpha-2 agonist because they have ADHD and they're fine. And then they go to someone and they say, I have insomnia. They give them an alpha-2 antagonist like mirtazapine. All of a sudden, they're not sleeping and their ADHD is out of control because it's a wash, right? The alpha-2 agonist is contradicting the alpha-2 antagonist and nothing's working. But if you didn't know that, you're going to be stuck all these out. What do I do? Do I try Adderall? Do I try trazodone? It's like you're stuck in a loop and you're not going to figure it out. Does that make sense?
Yeah, that does.
It takes more work, but you're going to be you're going to be like running circles around all the other practitioners, and all the patients are going to get better.
So you suggest learning it from like the receptor?
I think so. It really will make things so much easier for you, especially if you're going to work in very treatment resistant like settings where patients are going to come to you on every medication in the past, and you don't know where else to go because all these algorithms, quote unquote, were tried already. Unless you can pick out a pattern and say, okay, they've tried GABAergics, maybe we'll try serotonergics, or they tried all these meds that are doing this, maybe we should try this one. And the only way you would do that is by actually understanding the classes, how each one differ from each other, and how each receptor does what. It's the only way. Because if not, then you're going to do what everyone else does. People say, what's the stereotype for psych? Oh, it's trial and error. One med doesn't work, Prozac doesn't work, let's try Zoloft. Zoloft doesn't work, let's try Lexapro. But you're not helping anybody. And you're causing your patients to suffer for no reason. Phil sits with me for clinicals. Phil, how many of my patients are stable? Almost all of them are stable.
Literally every single one. Yeah.
That's awesome.
Yeah. But that's because, and you say it all the time, like the key is spending like, an appropriate amount of time on an intake to really like be able to appropriately diagnose and figure out what the major symptoms the patient is exhibiting, and then understanding, the neural pathways of where those symptoms come from and then how to treat them appropriately.
I'll spend 2 hours on a psych eval sometimes. What we'll do is we'll go through a list, all the meds that they can remember they've taken. I'll write down the mechanisms, explain it to the patient, and I'll tell them why I want to stop medications. Obviously, if these are higher functioning patients, but I'll still do that in a way to see, because sometimes patients will come to you, they'll have a list of all the meds they've been on, and you kind of have to keep track. Why didn't this work? Then I'll say, okay, this didn't work because you were on this med. For instance, you were on clonidine and mirtazapine at the same time. Okay, that's why it didn't work. Maybe if you try one, if the alpha-2 agonist was working, maybe all we needed to do was to switch your hypnotic medication, right? So you kind of have to see it and write it down and see why these meds didn't work. See if there's drug-drug interactions, right? Well, this medicine is working because you were drinking a lot of vitamin C at that time. All the amphetamines that your prescriber was giving you wasn't working because you were afraid of catching COVID for those 6 months and you were taking emergency every day, right? That's why it didn't work. Maybe we can try it now that you're not taking high levels of vitamin C, and it might work. Right? You have to be like a detective. Yeah.
What kind of approach would you recommend if you're getting like a low functioning individual who's on so many meds and there's a few breakthrough symptoms? Do you slowly just pick and choose what you would cut back on?
But that's a patient I would actually do pharmacogenetic testing. I've done that with a few of my patients. If they're poor historians and I just know what meds they're on, but they can't really tell me like specifically how they respond, I would do a PGX testing, which will show me if there's fast metabolizers or slow metabolizers or meds, and I'll use that as a starting point to kind of put things together.
Thank you.
But normally I don't do pharmacogenetic testing. I think it's useless unless it's this case with these patients. I would just do a level right away. Psych is fun. I'm telling you, once you learn all this stuff, it's really fascinating. And it's always, there's newer stuff coming out all the time. You know, I always try to keep up to date with newer meds also. So I always try to stay cutting edge. Whatever the newer meds are, obviously I research it myself and I offer it to my patients. But like I was prescribing, what's that new med? Auvelity. It's a dextromethorphan and an NMDA antagonist. And I have a few patients in my private practice doing very well on it. So I don't withhold treatment. I always try to give my patients like the cutting edge. But at the same time, I'm skeptical because I want to make sure these new meds are safe also. And I'm aware of what the possible interactions are.
I have a test kind of, so in a lot of the questions were about someone coming on with a substance abuse disorder with a mood disorder. What is the real takeaway if somebody has like an alcohol or substance abuse disorder and we're trying to treat them? Are there like some main popular ones?
For what? I'm sorry, for what? For ADHD or in general? What are you talking about?
Or like a substance abuse with a depression, a unipolar or a bipolar depression with a substance use disorder type of
So
thing.
someone has a substance use disorder, you want to first figure out, did the symptoms come about because of the substance use, or is it withdrawal or intoxication, or is it there organically that's separate from it, right? Because you don't want to over-medicate patients either. So ideally, you know, you want to treat them at the same time. So for instance, for my organization, we have a substance abuse program and a mental health program. So they're kind of like in both pathways. They have a clinician who specializes in substance abuse that's helping them with motivational interviewing, CBT, getting them off, and at the same time, I'm there managing their withdrawal symptoms or trying to keep them stable, right? And their underlying mood disorder. So to answer your question, you need to figure that out first. Is the symptoms due to the substance use, withdrawal, or intoxication, or is it organic by itself? And you try to tease it out and you treat and see. You don't want to have them both treated for this. If I can treat someone and get them off the substance and their depression is gone, I don't have to give them SSRI. I just want to get them off of the substance. Does that make sense?
Yes, thank
Ideally,
you.
you want to treat the substance first. So going back to what I mentioned in the past, diagnostic hierarchy, you want to treat substance abuse, traumas, mood disorder, anxiety, and then ADHD. That's the algorithm. Because if you don't go in that order and you treat ADHD first, you can worsen anxiety and actually worsen substance abuse also.
I have a question.
Yes.
For patients on high dose D2 blockers, like for psychosis or schizophrenia, what's your best recommendation for like negative symptoms like concentration?
That's the most challenging part. I've tried, so sometimes I'll try alpha-2 agonist off-label, right? I'll use stimulants also, right? As long as they're on long-acting injectables, so I know they're not going to miss doses of their D2.
Yeah.
I've obviously Vraylar. The only time I don't use Vraylar is if there's a history of aggression and they really need that strong D2 blockade. A partial agonist is not going to cut it.
Right.
Sometimes I will use a low dose of Vraylar or a low dose of aripiprazole, not enough that it's going to bounce off that D2 antagonist, but enough to innervate. Right. This is kind of like advanced, but just know that if you give someone a D2 partial agonist, has a stronger affinity at the mesolimbic area for D2 receptor. So if someone's on risperidone 3 and you give them Abilify 10, there's a risk that Abilify 10 will actually bounce off that risperidone, right?
Yeah.
But if you go very slow, sometimes you can give someone risperidone like 4 or 5, which is going to block dopamine in the mesolimbic area for psychosis, right? But they're still having less dopamine in the frontal lobe.
Right.
You want to give them a little bit of dopamine there. How can you do that? You might give them a little bit of a dopamine partial agonist like aripiprazole, maybe 2 milligrams, maybe 5. And then in theory, it's going to increase dopamine in the mesocortical area only, but not be high enough that it's going to bounce off the dopamine blockade in the mesolimbic area. Sometimes by stimulants, sometimes Wellbutrin, alpha-2 agonist, obviously.
Yeah, I was thinking Wellbutrin, but yeah. Have you done that in practice before?
I have, but you know what? The patients that respond best are the ones that have comorbid depression and not negative symptoms. But the problem is you can't tell the difference. It's very hard to tell the difference between depression with schizophrenia or is it negative symptoms from the schizophrenia, because they look almost the same.
Exactly, yeah. Because it would be the same issue like if you have like a patient with ADHD and schizophrenia, for example, right? Like
it's hard to tell where it's ADHD or where it's negative symptoms also. Yeah. Which is why we're kind of moving away from that. We're using more like, instead of like diagnosis, it's more of like the symptoms.
The symptoms, yeah, of course.
Which is called RDoC. So a lot of the studies now use research domain criteria, which are not actually, they're just looking at the symptoms, right? People have cognitive issues. Doesn't matter if it's cognitive issues from ADHD, cognitive issues from bipolar. We know that if we increase dopamine, norepinephrine in your brain, it's going to help that across the board, not just in that disorder.
Right. Cool. Thanks.
Or sometimes if you go too high too on the D2 blockade, it could be secondary to that. So what you can also try is, if not aggressive, maybe go down on D2 blockade and see if it's medication-induced negative symptoms.
I see. Yeah. And what about for like sexual dysfunction though with high D2 blockade? Would you still
So
do?
if someone's on, yeah, I would do prolactin level and see. And then if it's due to hyperprolactinemia, obviously you can either switch the medication to one that's not. If it's like Risperdal, maybe
Right.
like olanzapine, or you can give them a partial agonist if that's the only medication that works for them. Again,
Right.
not high enough that it's going to override the D2 blockade though, the mesolimbic area.
Of course, yeah. Yeah. It's a tricky science.
Yeah. You know, psychiatry is an art and a science, right? Like what we're talking about is part art and part science too. Like you could be the best psychopharmacologist, know all the receptors, know all the ins, but you're terrible at getting patients to take medications. And then what's the point? You're useless, right? Because you can't talk to patients and no one wants to take the medicine from you anyway. So you have to have both. You have to be like a car salesman.
Can you explain again the affinity part that the receptors?
Yeah,
for
so
the-
Ki value is what determines affinity
Right.
to the receptor. So the lower the Ki value, the actually stronger it attaches to the
Stronger.
receptor. So any Ki values that are below 10 is significant. Any Ki value that's above 10 is usually not significant. So for instance, if Abilify's Ki, and this is just, I don't know the exact Ki, it's like, I don't know, it's 2, right? And Risperidon's Ki value, the D2 receptor is 15. Obviously, Abilify is going to beat that out because Abilify's Ki value is 2, and that's 1 divided by 2, and then 1 divided by 12, right? Because it's an inverse. So it will beat it. Don't worry, I'm not going to ask you about Ki values in one drug versus another in the final. But I might ask you that when you get to clinicals, though. Great questions. Anything else is not clear?
For SSRIs in pregnancy, I know that they say sertraline is one of the ones that is good for pregnancy. And but I know it has a lot of side effects. Is that the only one, or are there other ones that are like okay to use in pregnancy?
So we normally use it. If you go online, you can type in relative infant dose, and then so relative infant dose is the proportion of the drug that's inside the breast milk that actually. So sertraline, the relative infant dose is very low, so barely any of it goes to the breast milk, so you can breastfeed with it safely. And also, apparently, it's also safe when the mother is pregnant, also.
Right.
So the side effects of sertraline usually have more GI side effects. That's why we call it squirtraline. So more diarrhea, more nausea and vomiting.
Right.
Yeah. But it is if someone wants, but you know, for the most part, like I've actually seen patients on Paxil. You know, Paxil is notorious because it can cause cleft palate. But if a patient has really, really bad depression, and Paxil is the only medication that's caused them to stay stable and not try to kill themselves, it's a risk benefits thing. I've even seen patients stay on Paxil. They're aware of what the risks are, but suicide is also, you know, is bad as well. So you kind of have to weigh those.
Okay.
Yeah, for antipsychotics, Latuda is one of the safest ones in pregnancy. Lorazepam. And lithium can be used after the first trimester. All right, Depakote, none. Don't use Depakote at all during any parts of pregnancy, or even when they're trying to get pregnant, right? But lithium is really dangerous in the first trimester. Why? What does it cause?
Something with the heart.
Yes, Epstein's anomaly, right? If you take LIT from lithium, LIT stands for low implanted tricuspid valve, which is Epstein's anomaly. So the heart becomes malformed. But after the first trimester, the heart's already formed. So lithium is not going to reverse that. Once the heart is formed already, you can take lithium. But just make sure that you adjust the dose, because during pregnancy, depending on the trimester, lithium excretion changes. I don't know off the top of my head, but just do a regular level to make sure that you adjust it accordingly. So you can use lithium during the second and third trimester, but not during the first trimester. That was my dog. My dog's like running around my house.
What did you say about Latuda a minute ago on pregnancy?
I'm sorry. What happened? What?
It's safe in pregnancy. It's
Lithium.
Latuda.
Oh,
Yeah.
Latuda. Yeah, Latuda is safest during pregnancy because not a lot of it crosses.
Okay.
Guys, I'm sorry. Give me 1 second. Sorry. All right. Any questions? Sorry, I'm keeping my puppy here because he's fighting my other dog. So.
Aw.
All right. Other questions you have?
Can you just go over quick, like basic, the pathways, the limbic pathway and where the things are and what follows what really quick, just to how an easy way to kind of.
So limbic system is composed of like a lot of parts, right? But the most important ones to really know is amygdala is one of them, right? Because amygdala is the emotional part of your brain. The fear response is driven by the amygdala, fear and panic. Hippocampus obviously is for memory. So hippocampus is where a lot of negative memories can be stored. And that obviously projects to the amygdala also. So let's say, for instance, I don't know, you got bit by a dog, right? I have a dog, but that's going to be connected in your hippocampus. And obviously, whenever you see a dog, it's that connection from the hippocampus to the amygdala is actually going to cause the amygdala to hyperfire, right? And then when the amygdala hyperfires, it's also going to trigger your locus coeruleus to secrete norepinephrine, right? That's your fight or flight response, right? The frontal lobe, you have different parts of frontal lobe, but you have like ventral medial prefrontal cortex, the orbital frontal cortex. Those also regulate your limbic system because that's what overrides the hyperactivity. So when you go to therapy and they say, well, you were attacked by a dog when you were 5 years old, now you're 35, that happened in the past, that might not happen again, right? A dog is not just going to attack you like that. So you have to kind of get that in your frontal lobe, and that's going to override your hyperactive amygdala, right? If that makes any sense. So in therapy, you're trying to get that connection stronger, which sometimes is lost during trauma. So sometimes during trauma, there's a disconnect between your hemispheres, right? Your left and right hemisphere are disconnected, right? And that's connected by your corpus callosum. So in therapy, when people do EMDR, which is eye movement desensitization, when they make you look left, that's activating your right side of your brain. When you look right, that's activating your left side of your brain. So when you do the narrative of talking about the trauma, you're talking about the trauma, but you're looking left or moving something left and right, and that's activating both sides of your brain. So that's really the most important part. Frontal lobe overrides hyperactive limbic system. Right, so that's also called regulation from the top. If you ever read the NEI book, they talk about regulation from the top down. That's regulation from the top down, right? Because you're dulling down the hyperactivity of your brainstem from top down. Your cortex is telling it, look, this happened 30 years ago. It's not happening now. So that's called top down.
So the EMDR works on like which areas of the brain?
It just EMDR in theory connects your left side and your right side of your brain. So what happens is if you have a trauma, sometimes you only process it on one side, whether it's left or right, depending if you're lefty or righty. So what you're trying to do is you're trying to make sense of it. Because the thing is, if you get trauma and it only affects one side of your brain, you get something called alexithymia. You heard of that term before? Alexithymia?
No.
Alexithymia means that someone cannot put emotions into words. So that's sometimes that manifests as like a conversion disorder. So a patient who was, I don't know, raped or something, right? They can't put fear into the meaning of it. So therefore, whenever they see, I don't know, a certain type of man or a certain type of woman, they all of a sudden lose their vision, or they can't walk, or they start having seizures, right? Because they can't put words to it, and that left and right brain is not connected. It manifests as physical symptoms. And sometimes that can happen too, right? They have a stomach ache that doesn't get better, they have all these physical symptoms, and whenever they go to the doctor, there's nothing there. And they refer them to us saying it's psychosomatic. And then you do some interview and you find out later on that it was trauma related. So then what do? You refer them to a trauma therapist, and you treat them with, alpha-2 agonists, right? Or beta blockers, or maybe, SSRIs to dull down the amygdala.
So basically, EMDR desensitizes your emotions from the events.
It makes sense of it. It processes it in a way. So it just connects both sides of your brain so that you can make sense of it. Because when strong emotional events happen and they're fragmented in different parts of your brains and the left and right side are not connected, it can express as other things, whether it's depression or anxiety or conversion disorder, right? Which is like psychosomatic symptoms, headache, blindness, they can't walk. But then when you go to the hospital, they're medically fine.
You said you would treat that with beta blockers, and what was the first thing you said?
You can use alpha-2 agonists too for nightmares.
Okay.
Alpha-2 agonists, you can use prazosin, alpha blockers. So anything that dulls down the sympathetic response, right, at the locus coeruleus.
Can you go over BFP again? Those three medications are 3A4 inhibitors?
Yes, well, butyrate and bupropion, which we use for depression or smoking cessation. Fluoxetine, which is used for anxiety or depressive disorders, and paroxetine, which is used for both anxiety and depression.
But all three of those are 3A4 inhibitors?
Not just 3A4, 2D6 also, and all other. They're pan inhibitors. They inhibit a lot of the different CYP enzymes. But we just usually say 2D6 because 2D6 is the predominant substrate in psychiatry. But to be more exact, it's more than 2D6. It's 3A4 also.
And the reason why they cause all these problems is because they're very strong inhibitors, or just
very strong inhibitors. Yeah. Sertraline, if you look at some of the medication, like what do you call those things? Like Hippocrates, it'll mention that sertraline is an inhibitor also, but it's a moderate inhibitor, but only at high doses. So sometimes we use sertraline at high doses for what? Tell me. What do we use sertraline high doses for?
OCD.
Very good, right? So actually I've used sertraline as high as 400 milligrams for patients with treatment-resistant OCD. So if you go at like 200 or even 150 milligram, it becomes a moderate inhibitor. So at high doses, it's a moderate inhibitor. If you go to 400, then of course it's going to be a strong inhibitor. So just be careful with that too. Usually it's the strong inhibitors that are really important, because a lot of meds are like small, they're like weak inhibitors or, intermediate inhibitors. It doesn't really make clinical significance. And I'm going to ask what the meaning of life is. I know it's a lot of material, so it's all right. I'll wait. We'll go till 10 o'clock so you guys can get your money's worth. This is the last lecture anyway.
Can you just talk a little about the dorsal striatum, nucleus accumbens, and hypothalamus, just to review for me?
Oh, all right. So dorsal striatum, the importance about it is that it's the movement pathway. So if there's issues with dorsal striatum, the dopamine neurons in the nigrostriatal area has to do with the dorsal striatum, right? So that's going to be the movement disorders. So when you block dopamine there, it can cause, Parkinsonism, tremors. It can cause dystonia, stiffness, right? How does dopamine affect Parkinsonism? Do you guys know? I'd be very impressed if you guys can actually break it down for me. Do you guys know the pathway of how it works?
Yes.
All right, go ahead, Phil. Let's try. Tell me.
I don't really like know it super well, but I know that like isn't dopamine, it innervates nigrostriatal area, which causes some sort of movement disorder. Like,
So it actually has to do with acetylcholine, but what happens is there's two GABA interneurons that are next to each other. So dopamine is inhibitory. So it inhibits GABA. So GABA is not going to secrete to the other GABA. And then it goes to an acetylcholine neuron, which actually hyperfires acetylcholine. And the acetylcholine is excitatory. So it causes all those spastic movements. It's hard to visualize as I draw it out, but. So yeah, dorsal striatum movement. Just know that. Dorsal striatum movement. All right. Ventral striatum or nucleus accumbens has to do with reward, addiction, psychosis, motivation. All right. What was the other one? Hypothalamus. Hypothalamus has to do with hunger, sleep, thirst. All right. It's connected to your pituitary gland, so that can affect a lot of endocrine stuff too. So sometimes, if someone has schizophrenia, they get something called psychogenic polydipsia. You guys ever heard of that before? Psychogenic polydipsia. So that's actually the hypothalamus is affected there. So patients are constantly drinking. And what happens? They drink themselves to death, right? They get hyponatremia, they have a seizure, and then they could die. So what happens in the hospital? They usually put them on 1-to-1, right? If someone develops something called psychogenic polydipsia, we usually give them clozapine because clozapine actually reverses that. So clozapine is good for treatment-resistant schizophrenia, treatment-resistant mania, and psychogenic polydipsia. So people literally will drink themselves to death.
Can you repeat one more time how the 5-HT2A is a block in some of the dopaminic?
Yeah, so when you block 5-HT2A,
Yeah.
right, it's actually going to increase dope. So any medication like olanzapine, risperidone, Latuda, all these are 5-HT2A. These are atypical antipsychotics. They actually, when you block 5-HT2A on a GABA interneuron downstream, it's actually going to increase dopamine in the nigrostriatal area and the mesocortical area.
Okay.
So it's, less EPS and less cognitive issues in theory, but sometimes you don't see that. It still happens.
But it's a dopamine break in the mesolimbic area.
In the mesolimbic area, we don't really have that many. It doesn't really affect it at that point. Yeah, so it's not going to increase dopamine in that area.
Shoot. So what I have in my head that 5-HT 2A is a break and 1 is the accelerator. No.
I want to make sure I'm giving you the most accurate information. So let me get back to you on that. In the mesolimbic area, there's a possibility there's not enough 5-HT2A receptors for that to be significant, but I want to make sure I give you the most accurate data.
Okay, that's all right. I might be confusing everything.
Yeah, but definitely just know it doesn't affect the mesolimbic area. It affects, because if that was the case, give someone 5-HT2A antagonist, it's going to cause psychosis, right? Because it increases dopamine in that area. Why would you want that? Yeah.
Okay, I got you. Okay, so it's just that doesn't have the effect that.
Yeah, it just doesn't have the same effect. Whether it's because there's not many present or it's just not there. I'm not sure.
Thank you. Okay, that makes thank you.
Because parts of the brain, like you guys know there's 5 dopamine receptors, right? There's D1, D5 like, which are excitatory. There's D2, D3, D4, which are actually inhibitory. For instance, in the frontal lobe, you don't have D2 receptors. You only have D1 receptors. So you kind of have to know where in the brain they're located to do different things. But that's kind of advanced. I don't expect you guys to know that now. Same as 5-HT2A receptors. There's certain parts of the brain that have more. Remember, epigenetics determines what type of receptors you have in certain parts of your brain, right? That's the reason why some people are more anxious, some people are more prone to psychosis, because, epigenetics means that your life experiences causes certain genes to actually come out, right? It's not changing your genes, but it's causing those genes to be expressed more than others, whether those are genes that causes your brain to express more serotonin receptors, right? Or those genes that causes your brain to have more dopamine receptors, or your dopamine receptors to be more sensitive. Who knows? Maybe that's the reason why some people are more prone to psychosis. We don't really know. So that's also why some people respond. That's what I tell patients, right? They say, well, you know, how come these meds don't work on me? I try to explain to them, well, it's epigenetics. Sometimes parts of your brain have more receptors than others. Therefore, if I'm targeting these receptors, but your brain doesn't have that many, it might not work for you. Right? We can't just give everyone a serotonin reuptake inhibitor and it works for everybody. It doesn't. And some of the explanations are whether it's a different type of depression, right? Is it more inflammatory? Is it more due to dysfunctions of different pathways? Is it not serotonin, more dopamine, more norepinephrine? We don't really know. Or is it epigenetics? There's like so many factors. But you should actually understand the different ways because you can kind of figure out, okay, we tried this pathway, let's do this one. So you don't repeat the same things that were tried before. So you also have an understanding of how to treat the patients by understanding those different mechanisms.
Right. I think I thought I read somewhere that depressed patients have less 5-HT2A receptors, and that kind of helped me make some sense of.
Yeah, that's why some people respond to psychedelics, right? Ketamine.
Yeah.
Yeah, that's the
That
reason
made
why.
it a little bit more sense in my head.
But not everyone's depression is always manifest. That's why you don't have biomarkers, right? We can't just say, well, your cortisol is high, therefore you have depression. Because not everyone is in depression due to hyperfunctioning of their hypothalamic pituitary axis, right? Some people have it because it's more 5-HT2A, so you give them psychedelics and they're fine. Some people, it's more serotonin, so you give them a serotonin reuptake inhibitor and it works, right? It's all different. That's the challenging part about psychiatry, because the DSM, you know, in reality, it's not really a good way of. It's not like, I guess, you know, microbiology where you can say, well, you have a gram-positive staph infection or something, right? You give them an antibiotic and it works. We don't really know who's going to respond to which treatments, but at least if you have a general understanding, the way I'm teaching it now, you can kind of figure out what's been tried and you can make the best educated, you know, I wouldn't say guess, but deduction or inference to see which meds might work for this patient. And there's actually some, you know, there's some people that if they don't respond, we do a CRP, and there's actually some studies that show that a high C-reactive protein, patients, you know, have more inflammation and they respond better to Wellbutrin, right? They don't respond to SSRIs for whatever reason, right? So there are some, but I would try the regular before you go that way.
So back to the 5-HT2A. So primarily it is a serotonin stoppage, but depends on what area of the brain.
Yeah, depending on the area of the brain, correct. Yeah.
So like, can you give?
Depending on where the thing is, remember, GABA interneurons sometimes are connected to glutamate neurons too, depending on where it is in the brain. So if it's just GABA that's connecting directly to the VTA, then of course it's going to do one thing. But if it's a GABA interneuron that's connected to a glutamate, then connected to VTA, it's going to do something totally different.
So it depends on the innervations.
Yeah, depending on what's there. Is it GABA? Is it GABA glutamate GABA? It really, you know. Seems like you guys are all understanding it. You guys are kind of getting the flow, which is good. Imagine if this class was 14 weeks instead of 6 weeks.
Bye.
Is it the new cohort? They have it for a full semester?
You mean the psychopharmacology class?
Yeah.
It's only held in the summer.
I think they changed it. No, aren't they taking it in a fall or spring?
I'm not sure. I mean, no one told me about that. Have you heard about that, Phil? I don't know.
I think that he is correct. Oh, I mean, I don't know. That's what Metal said. It was how it was going to be set up, but I know that they've made a lot of program changes.
Yeah.
So
I mean, I wouldn't mind teaching this course if it was longer. Obviously, there's a lot of material, and I kind of feel bad because I'm kind of like skimming through it, and I really want to go into detail about a lot of stuff, but it's just, you know, it's too much. And I'd rather you guys get the essence of it, and we'll just fill in the gaps as you guys go into clinicals. It'll be reinforced again as you get into clinicals anyway. So going back to SSRIs, just know that for depression, we tend, so I'll give you an example. Zoloft is the best example, right? So Zoloft 50 or even Zoloft 100 would be effective for depression. If someone has GAD, for whatever reason, we tend to go a little bit higher because the amygdala is hyperfiring and you need a little bit of a higher dose to kind of dull it down a little bit. So for anxiety, usually the sweet spot would be like 100 milligrams of Zoloft or sertraline or 150 milligrams. For OCD, you actually have to go higher. So either 200, or if you have to, I'll go all the way up to 400 milligrams. All right. So for depression, people tend to respond at the lower doses of SSRIs. For anxiety, you have to go a little bit higher. For OCD, go much higher. Because the thing is, you don't want to abandon treatment too early. So if someone has OCD and Zoloft 50 or 100 doesn't work, you don't want to say, well, Zoloft's not working, let's stop it. No, you got to push it up. As long as they're tolerating it. Why don't I use Lexapro for OCD? Why not Lexapro? Because it can cause EKG problems once you go above 20. So I wouldn't recommend going above 20 on Lexapro. QT prolongation, all right? So I usually go either Prozac, high dose, above indication if I need to, super therapeutic, or I'll use Zoloft, sertraline. If that doesn't work, I'll use fluvoxamine. Right? Fluvoxamine is Luvox. It's an SSRI that's only FDA approved for OCD. What's the problem with Luvox? What is it? It's an inhibitor of what enzyme? 1A2. All right. So I'll give you an example. All right. This is why it's important to understand pharmacokinetics and have a general understanding of this. So I had a college student. She was 22 years old. And of course, she was studying. So she drinks a lot of caffeine. Right? What's caffeine? Caffeine is a 1A2 substrate. So she didn't have panic attacks before, but she only had OCD. So I put her on Luvox, and all of a sudden she was having panic attacks, right? If you didn't know that caffeine was a 1A2 substrate and Luvox was a 1A2 inhibitor, what would you naturally do? Well, it's an SSRI, let me go up higher. And what's going to happen? The panic attacks going to go up higher, right? So I knew right away, okay, how much coffee do you drink? I drink like 4 or 5 cups of coffee a day. All right, good. I'm going to save you some money. Now that you're on Luvox, just buy 1 cup of coffee. You'll be fine, right? So she only drinks 1 cup of coffee. This is an inhibitor. She still gets that same potency. She saves about $20 a day and she's fine. OCD is perfect. All right. But if you didn't know that, this is how polypharmacy happens. All right. Let's raise up the Luvox. All right. Now she's having really bad anxiety attacks. Okay. Now let's put her on Klonopin. Then she ends up on Klonopin and a high dose of Luvox, and you don't know why she's having panic attacks. You see what I mean? And that's irrational polypharmacy. Meanwhile, if you figured out, okay, it's because the caffeine use is being increased because I'm giving her a 1A2 inhibitor and she cuts down on the caffeine and you go up in the Luvox and her OCD is fine. Right? But you wouldn't know that unless you understood the concepts I gave you.
Sorry, I have 2 questions now.
Sure.
So today I was reading, there was another drug too. I guess it is a 1A2 inhibitor, but I didn't remember what it was. That like it competes with caffeine as well. What other drug does that?
There's a bunch of 1A2 inhibitors. It depends on what it is. There's Luvox, ciprofloxacin. So if someone's on clozapine and they get a UTI, they get put on Cipro. You can't get put on the Cipro. They have to use something else. Antifungal meds are 1A2 inhibitors. Ketoconazole. Is it that one?
That might have been what I read today.
Yeah.
And then what's the mechanism? Like, why do you have to go so high with Prozac for it to work on OCD versus the dose for the antidepressant?
We don't really know the reason. It's not a pharmacokinetic reason though. The person's metabolizing it normally. You just need more serotonin for whatever reason to dull down that anterior cingulate cortex, which is implicated in OCD, right? So anterior cingulate cortex is the part of your brain that kind of tells you when it's your check system. So when you see, let's say for instance, you organize something, right? And you put your papers together. We believe that your anterior cingulate cortex fires serotonin, right? And it tells you, okay, it's fine, and you're comfortable with that. For people who have OCD, they have misfiring connection to anterior cingulate cortex. And what happens is, for whatever reason, the serotonin receptor doesn't get innervated, and therefore they have to constantly check and recheck stuff again. So what you're technically doing is you're trying to fix that circuit by increasing serotonin, whether it's, you know, through Prozac or Zoloft. All right, it just needs to be much higher. Final 9 minutes. So if someone is complaining of inattention, what should you check first? Look at their meds and look for meds that are what? Anticholinergic. Right? So if someone's complaining of cognitive issues, go through their med regimen, do reconciliation, wherever it is, and see, are they on too many meds that are anticholinergic? Wean off the anticholinergic meds. Remember, you have to wean them off though. There's anticholinergic withdrawal also. So for clozapine, if someone develops, I don't know, myocarditis or develops symptoms of clozapine toxicity, you don't just stop clozapine cold turkey. What's gonna happen? They're gonna have withdrawal from the anticholinergic. They're gonna have what do you call that? Delirium, right? Delirium from the anticholinergic withdrawal. So what you want to do is you want to actually bridge them with another anticholinergic med. And what's an anticholinergic med we can give them for clozapine? Cogentin. So for every 100 milligrams of clozapine, you give them 1 milligram of cogentin. If they're a non-smoker, if they're a smoker, it will be 2 milligrams of cogentin per 100 milligram of clozapine. All right, and then you wean them off. 25% reduction in the cogentin every week till they get off. You don't just stop the clozapine cold turkey, right? That's important. You never stop any anticholinergic meds cold turkey. Even olanzapine, you don't stop the cold turkey. You have to wean them off because of anticholinergic withdrawal, which could be insomnia, and it could be activation and agitation also. So if someone's having insomnia and you're wondering why they're having insomnia, it could be because they stopped their olanzapine. Let's say they were on olanzapine 30 milligrams and they just stopped taking it. That's why they have insomnia, because they're having anticholinergic withdrawal. There's also something called supersensitivity psychosis. Have you heard about that term before? Supersensitivity psychosis means that if someone's on a long-term dopamine blocker in the mesolimbic area, what happens when you block those receptors? Those receptors are going to upregulate and they can become very sensitive. So what happens when you stop, if they stop the antipsychotic medication cold turkey, you're going to have a flood of dopamine neurons that are going to innervate the postsynaptic neuron, and it's going to be upregulated and more sensitive. They're going to be even more psychotic. So I warned the patients that way. So supersensitive psychosis happens in the mesolimbic area. If that was going to happen in the nigrostriatal area, that would be tardive dyskinesia, right? Upregulation and very sensitive receptors at the dorsal striatum. Does that make sense? There's a class of antibiotics that are known to cause psychosis. Do you guys know? Which class of antibiotics can cause psychosis?
Isn't it the quinolines?
Fluoroquinolones, yeah. We don't know the exact reason why either, but it's interesting.
How do you spell that?
The fluoroquinolones.
Oh.
Oh, by the way, I'm supposed to remind you that please do your survey. All right. And be honest, if you feel like I was too strict or if the material was too much, I don't take it personal. But I do, I do want to improve my teaching. So if you felt like the material was too much or I wasn't, explaining it correctly, please write your, write in your surveys. Just fill it out.
Too short.
Too short. I don't know. Not unless you take me again for 517, then you get an encore.
No, but like for a foundation class where our clinicals are going to be based on a 6-week.
Well, this is a taste though. This is really just an introduction. We're going to go into more detail once you get to clinicals. Trust me. This is just a taste.
I have a question, Professor. When I was looking at percentage assigned to different sections, right, for the entire course, it doesn't total up to 100. Do you realize that?
It doesn't add up to 100?
I mean, it's like it comes out to 90. Is it?
Yeah, because 10% is NEI.
With NEI.
With NEI, really?
Uh-huh.
So I guess 10% we just give it to you for free.
Oh, okay.
So like, technically no one can get a 0. The highest the lowest you can get in the class is a 10.
It's
Okay.
30 for the midterm, 40 for the final, 10
High
for
five.
NEI, 10 for case study 1 and 10 for case study 2.
Oh, so the case studies are 10 and not 5? Syllabus was saying 5.
Maybe
They did
5%,
say-
each is 5%. 5, 10.
The case studies are 5.
I believe so.
It said 5 one place and 10 somewhere else. So that's why I figured it added up to 100.
Whatever equals 100. I mean, most of you guys did very well in your case. I didn't take off any points for a lot of you guys, so that's that's an easy give me. Really, I want you to understand the exam. It's really the exams that's gonna make or break you. And if you go and rate my professor, please don't give me 1 star. I don't want people to be scared and not take my classes in the future. Any final questions?
Is there some stuff on the exam that we haven't covered at all today in today's review that maybe we're missing?
So the exam's not complete yet. I'm actually going to finalize it probably tomorrow. So I'm going to look over what questions Professor Smith put, and I'm going to put my questions, and then I'll make sure it's fair. All right. So, I mean, there might be a few that weren't covered, like I said, just to make sure that you guys were reading outside, because it's impossible for me to cover everything. But if you attended my lectures and you did the readings, you should do more than enough to pass the exam.
If you want to send me a copy to look it over for the class, I'll volunteer for that.
All right.
Just email it to me. I'm around all day tomorrow.
So you guys are gonna, so the 3rd, I think, is when it opens up, right? You guys have 24 hours to do it. All right, you'll be fine. I'm gonna look over, I'm gonna make sure it's fair. And look, like I said, if a question doesn't seem like it was fair, we throw it out. We gave you guys 10 points the last test, which is a lot.
Professor, question. Can you go back in this test as well as last time?
Yes, you will be able to go back.
And the other thing is that I just wanted to let you know that the class, yes, it's very like 6 weeks, but I think the other thing that should be like corrected in future should be like the book.
Yes.
Because I think there should be like 1 book, because STALS for me was too complicated. NEI was like complicated to the max. And then this book, the Edinger book, was a little too dry for me. And as you said, there's many like problems with it. There's like, contraindications or like, it's not correct. So I think for future reference, I think you should definitely focus on which book you want to use for this class.
All right, no problem. Yeah, I think we're gonna try to find a middle ground between NEI or STALS and the required reading, something that's like in between. Because I feel like the required reading was dry and a little too simplified, and STAL was a little too complicated, but all right, thank you. Any other questions, anyone? Any other comments? All right, well, thank you very much for staying up with me on a Friday night. All right, you guys could have been clubbing, but good luck in your on your final. All right, you guys are gonna do great. If you have any other questions, just shoot me an email, and I'm gonna work on completing the final exam tomorrow. All right, take care. Have a good night.
Thank you, Professor. Good night.
Bye bye.